This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, executive editor of the Breakthroughs newsletter. Results from a randomized phase 3 clinical trial just published in the New England Journal of Medicine could change the way women are treated for later stage endometrial cancer. Northwestern's Dr. Daniela Matei led the trial and is here with details. She's a gynecologic oncologist and physician scientist here at Northwestern and is the co-leader of the Translational Research in Solid Tumors program at the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Thank you so much for joining me.
Thank you, Erin, for having me here. It's such a pleasure.
Endometrial carcinoma is the most common type of gynecological cancer in the U.S. And in general, endometrial cancer, which is also called uterine cancer, is on the rise. Can you share with me some background about the disease?
Yes, that's right, Erin. Endometrial cancer is the most common of gynecologic cancer, with approximately 62 new cases being diagnosed every year in the United States, which leads to the fact that the lifetime risk for developing endometrial cancer for any given woman is about 2.9%. And in parallel, mortality from endometrial cancer has also been going up by about 1.6% a year in the United States.
And we're going to get into a little bit of the results of your trial, but right now, what is the standard of care for people with early stage and then late stage endometrial cancer?
So for patients diagnosed with early stage endometrial cancer, the standard treatment is surgery, and then tailoring to the risk for local recurrence, radiation is being used as well for those patients at higher risk for recurrence. In respect to patients with stage 3 and 4A endometrial cancer, which represents the patient population for my trial, the GOG 258 trial, typically these patients undergo first surgery. Historically, radiation was part of the treatment. However, over the past 10 years, several US-based as well as international studies have shown that use of systemic chemotherapy prevents distant metastasis and distant recurrence in these patients. And this led to the incorporation of systemic chemotherapy in the treatment for this patient population. The big question, though, remains whether these patients after surgery need both chemotherapy and radiotherapy, or whether chemotherapy alone could do the job. And this is the question that we are asking in GOG 258.
So this latest clinical trial published in the New England Journal of Medicine may help end some of this debate. Tell me about the trial and what are the results?
So this is a large international randomized study performed predominantly in the U.S. and run through the Gynecologic Oncology Group. This is Protocol 258, as it's known in the field. And basically, this trial randomized over 800 patients to either a combined regimen, which was the experimental arm, consisting of 2 cycles of chemotherapy given together with radiotherapy, followed by 4 cycles of chemotherapy, against the control arm, which was chemotherapy alone, given for 6 cycles. The primary endpoint of this study was to measure recurrence-free survival, hoping that the combined regimen would lead to an improved recurrence-free survival. And we also had some secondary endpoints, such as measuring acute and chronic toxicities, patient-reported quality of life, as well as overall survival.
The gold standard has been using radiation with these patients, and sort of you expected that that was going to continue to be the gold standard. That wasn't the case when you got the results.
That's right. The trial was supposed to be a positive trial, demonstrating that the combined regimen was superior to chemotherapy given alone. However, the results with a median follow-up of 6 months show that the recurrence-free survival for the 2 arms of the trial were very similar, 59% for the chemoradiation arm and 58% for chemotherapy alone. In terms of toxicity, the regimens were both relatively well tolerated, with slightly more toxicity for gastrointestinal, constitutional, and musculoskeletal events, higher in the combination arm. But also importantly, we measured patient-reported outcomes and noted that the quality of life indices were slightly decreased at the end of therapy, and this decrease persisted for about a year after treatment for the combination arm compared to the chemotherapy alone arm.
Because there are some side effects that come with radiation.
That is right. This is why the results of this study are important. Here we show that the combined modality regimen did not result in an improvement in recurrence-free survival. And the results of this study support that chemotherapy alone should remain the standard of care for stage 3 uterine cancer. And our data are indeed compatible with findings from prior studies showing that completion of chemotherapy is key to preventing distant relapse.
So how do you think the oncology community is going to react to this? This trial does carry some weight. It's the gold standard here.
This trial will be debated in the short and long term. And this will be a difficult change because radiation has been used historically in this group of patients and clearly has a role reducing the rates of local pelvic recurrence. And even here in this study, we show that patients who were randomized to the combined modality treatment had lower 5-year incidence of vaginal, pelvic, and para-aortic lymph node recurrence compared to those patients who received chemotherapy alone. However, these patients eventually will succumb to disease because of their high risk for systemic, outside of pelvis failure. And for this risk, chemotherapy alone is clearly beneficial and should remain the mainstay of treatment.
Is this something you're going to start using in your own clinic?
Yes, we have adopted this here at Northwestern. We still have lengthy debates in our tumor board and are trying to individualize treatment for each patient by trying to assess or quantify this ratio of the risk of systemic versus local recurrence.
You know, more and more women are now being diagnosed with endometrial cancer, and that's partially due to the obesity epidemic. Can you tell me about that?
You are right, Erin. There is a clear association between obesity and cancer risk. Very interestingly, among all malignancies, endometrial cancer association with obesity is the strongest. More than half of cases of endometrial cancer in the United States are in fact thought to be attributable to being overweight and obese. And there is actually kind of a dose-response relationship with the more obese you are, the higher the risk for endometrial cancer. How is that explained? I guess biologically, the visceral fat, which is composed of adipocytes and pre-adipocytes, is thought to secrete a number of adipokines, factors that stimulate both a state of chronic inflammation as well as these are factors that stimulate the proliferation of endometrial cells. So that is one mechanism by which obesity is linked to endometrial cancer. But also we know that obesity is linked to the risk of diabetes. And high levels of glucose, high levels of insulin and insulin growth factor have been shown in preclinical models to be stimulators for endometrial cancer proliferation. So again, hyperglycemia, insulin, the IGF factor all contribute to a pro-tumorigenic risk in this disease. And lastly, in postmenopausal women where the risk for endometrial cancer is highest, the adipose tissue is the main site for estrogen synthesis. The adipocytes and pre-adipocytes within the fat tissue are the main source of aromatase, the enzyme that converts androgens to estrogen. and the aromatase level as well as the estradiol level increase as a function of adiposity. So it is well known that estrogen also stimulates endometrial cell proliferation. So I think the role of adiposity linked to endometrial cancer can be explained through several biological mechanisms.
So many of the women that you see in the clinic are premenopausal, going through menopause, have gone through menopause, but this obesity epidemic does play a part in affecting more women than that population.
So it's true. Endometrial cancer is more commonly seen in postmenopausal women. The median age is about 60. However, we are seeing more cases also in younger women that are overweight and where obesity plays a role in, bringing up the sugar levels as well as the estrogen levels. So we are seeing an increase in incidence of uterine cancer in this subgroup of patients.
Another reason why this study is so important, because as maybe more women will be diagnosed with this cancer, you do have a treatment that really might work better.
That is true. We also it's also important to know that endometrial cancer is curable when diagnosed at early stage with surgery alone, and there will be many survivors. I think, in fact, more than 500,000 of survivors of endometrial cancer are currently alive in the United States. So their long-term functional status is very important, and omitting treatments that can have sequelae long-term is very important.
One thing to note, though, there is not really a good screening tool right now for this cancer.
There is not a good screening tool, but fortunately endometrial cancer presents with symptoms at early stage, and the symptom is bleeding. So any woman who would experience postmenopausal bleeding should be evaluated immediately. And that is unlike an ovarian cancer where symptoms don't develop early. So because of early symptoms, many of the cases of endometrial cancer can get diagnosed at early stage.
So you're also a molecular biologist, and your laboratory looks at the genetics of cancer. How is the field progressing in terms of understanding the biology of gynecological cancers and tailoring treatments?
I think a lot of progress has been made, and I'm very happy to state this because for 5 years ago that was not the case. With the completion of the Tumor Cancer Atlas program, we have now improved molecular data for both endometrial as well as ovarian cancer, and we're starting to understand both genetic risk factors for developing these cancers, but more importantly, we are starting to have new treatment tools that are based on the molecular characteristics of these cancers. For example, for endometrial cancer, we are now recognizing the role of mismatch repair defects that put these patients at risk for developing endometrial cancer and other cancers. And those patients who would have mismatch repair defects are eligible for newer forms of therapies, such as immunotherapy. In terms of ovarian cancer, we have recognized over the past 5 years the importance of homologous recombination deficiency, which affects more than half of the cases of ovarian cancer. And this explains the exquisite sensitivity of ovarian tumors to platinum drugs, and also has opened the venue to new treatment options such as the PARP inhibitors.
Speaking of ovarian cancer, another area you are studying is the role of cancer stem cells in ovarian cancer. What are cancer stem cells, and what role do they play in ovarian cancer recurrence?
So my laboratory has studied for the past few years the ovarian cancer stem cells. These are cells that are characterized by presence of certain surface markers, and they have properties of being more tumorigenic than the other non-cancer stem cells. They can self-renew and also differentiate into daughter cells. We know that these cancer stem cells are resistant to traditional chemotherapy and radiotherapy, and therefore we think that finding new characteristics or vulnerabilities will open the option of finding new treatments that can get rid of these resistant cells and hopefully lead to a cure.
So you're in your laboratory right now working on some of those things. You're in the clinic as well. You split your time between these two places. And I want to shift gears a little to talk about your life in the clinic. You see patients. You see patients at some of the most vulnerable times of their life. And you've developed bonds with a lot of them. One of your patients is the author and literary critic, Susan Gubar, who you treated for advanced ovarian cancer. She's talked a little bit about your relationship. Let's take a listen to what she said about you for an interview with the National Coalition for Cancer Survivorship.
I have a wonderful oncologist who is able to communicate with me and make decisions collaboratively with me. And I very much appreciate that. I just recently read Atul Gawande's new book, and he talks about a shift from doctor informative to doctor interpretive. Doctor informative says, well, there are 4 things you can do. It's up to you. And that's the kind of doctor Dr. Gawande said he used to be. And now he says he's moved from doctor informative to doctor interpretive, where he says, what are your values? What are your trade-offs? What are your goals? What shall we do? What's best for you? And my doctor has always been doctor interpretive. I'm very happy that she has been. I think it's partly because she's a poet. But I do think that talking is one way of creating a relationship between 2 whole people, not just doctor, patient, active, passive, but 2 people who are participating together in some kind of a collaborative decision.
So that's some high praise from one of your patients there.
Yes, it's true. I have a long and a very friendly now relationship with Susan Gubar, and I'm very thankful for her appreciation of my style. She's also said in her book that I'm a very direct and a truth teller. I don't really sugarcoat the findings and the facts, and I think that's true and might be linked to my background as an Eastern European person. This is indeed a difficult balance that I try to refine every day, and some days I'm better at it, and some days I'm not that good at it. But always, having the correct facts, I feel it's very important to be informative so that the patient can work with a physician to make the right treatment choice when different choices are available. I find this balance between my academic laboratory life and my clinic life as being rewarding, although sometimes it is exhausting. And the interaction with patients is a privilege, a gift, but also an overwhelming burden. And sometimes, at the end of a long, hard clinic day, it's hard for the doctor as well.
Susan mentioned in that clip we just heard that she called you a doctor poet. Is poetry a way for you to sort of escape when you're from the lab and the clinic and sort of the heavy lifting that you're doing as a physician scientist? Is poetry a way for you to kind of flex a different part of your mind?
That's right. I hope that in a different life I would have been a writer or a poet. And writing poetry, although it doesn't come that easy to me, I kind of work for months on a single piece, helps alleviate carrying the burden I spoke about earlier. My gift for writing has been very helpful, though, in my life as a scientist, writing papers and writing grants. But yeah, I value poetry. I wish I had more time for it.
Well, you did write one poem that does sort of address your life as a physician and scientist and then leaving when you walk out the door after a long day. It's called Bloom. Would you mind reading that for me?
I would love to write this poem. It was published in the Annals of internal medicine, and sometimes I joke that this was my easiest publication. It took me 10 minutes to write, about an hour to go through the submission process, and it was accepted without revisions. Bloom. I dressed up in my new tight, perfectly tailored Brooks Brothers skirt. I put on Mademoiselle perfume, blue shadow around my eyes, tan peep-toe heels before heading out. I kept my smile, the misty pleasant scent throughout the day. I did not flinch, sharing my compassion. Endlessly I shook hands, patted shoulders. I did not feel pain until 5 o'clock. When I walked out, spring was finally here. The balmy wind, blossoms on every tree. Cancer is pink.
Lovely. Thank you so much for sharing that. A note for physicians who listen to this show, you can now claim continuing medical education credit just by listening. Go to our website, feinberg.northwestern.edu, and search CME for more details. If you're a regular listener and enjoy the podcast, go to iTunes and rate us.